Again, good evening, everyone. Thank you for joining us on time for the program. And we are nearing towards the end of the whole program. Today, we are discussing on end of life care, and we have Dr. Roop as our faculty. And Dr. Roop is a consultant neurologist and epileptologist at Hinduja Hospital, Mumbai. And he is a founder trustee of FINE, which give education, provides education in neurology. And above all, he's a steering committee member of ILLICIT, which is an interdisciplinary task force of intensivists, palliative care physicians, and neurologists for end of life care. So I am sure that there is no one else who can speak about end of life care to this audience. Welcome, Dr. Roop, once again for being a part.
Hi.
Thank you so much for agreeing to come and take the session for us.
Not at all. Always a pleasure. Can you hear me? Am I
Yes.
audible?
Yes, very clear. And your background is very good.
Thank you. You should recognize it. Goa.
Yeah.
Okay. So I'm beginning by sharing my screen. Slides. Kya ho gaya? It's doing something else. Let me just take a minute. I think I opened. I had opened Zoom in two places. Yeah, got it?
Yes, sir. Good to go.
Okay. So, right. So let me begin by thanking Pallium India again for getting me to speak on one of my favorite topics. And I'll be speaking about end of life care, but it is not just as a doctor, it's also as a citizen. So towards the end, you will hear how it matters to all of us. So let me begin by finding my pointer. Yes, there it is. How many of us think about our own death? And if we do we think about dying with pain and suffering? So there's this very famous quip by a guy called Woody Allen, comedian, who said, "I'm not afraid of death. I just don't want to be there when it happens." Which is, I think, the attitude that most of us also tend to have. We look at quality of life in terms of our well-being, and that has been well assessed. But what about quality of death? Little difficult to assess it, but at a very basic, it means a good life till the very end, and it means minimization of suffering. But to minimize suffering, you need to measure it, because if you can measure it, then only can you work on improving. And it also requires us to be aware of patients' rights at the end of life. And I'll discuss that a little further along. You all know that palliative care is applicable to all serious health-related suffering, all. But at some point, things move towards a finish. And we call this end of life care when somebody has a prognosis of months to 1 year. Terminal care when it is weeks to months. And actively dying, often days to hours, and it is based on physiological parameters and usually irreversible. Now, very often, this part of it tends to be judged in retrospect, whereas these two start to become clearer and clearer. And we'll explain that. So some definitions: terminal illness is one from which recovery cannot be expected with the treatment that we have available, and death is considered to be unavoidable in the foreseeable future. Remember that this definition does not include a timeline. So somebody with dementia who's likely to die because of dementia, say even a decade, we would still call it a terminal illness. But end of life care is an approach to a terminally ill patient that shifts the focus of care to symptom control, comfort, quality of life, and quality of dying, with support for the family, so that treatments aimed at cure and/or prolongation of life can then be stopped. Right? Just give me a minute. I need to actually. Yeah, I need to. Yeah. Okay. I needed to quit my WhatsApp, otherwise it'll keep giving that noise. Right. So at that stage, treatments aimed at cure and/or prolongation of life can then be stopped. So now this paper and this graphic is something that we in palliative care use all the time. If you look at how people die, well, somewhere in the early 2000s, these authors looked at Medicare deaths. Medicare is a US government program that looks after people after the age of 65, and they looked at a fairly broad sample, and 92% of all deaths could be classified into one of these four trajectories. The first is sudden death, somebody who's functioning really well, and then suddenly death, right? And then there's terminal illness, organ failure, and frailty, and we look at all of them in sequence. Now, sudden death is actually pretty uncommon after the age of 50 years. Less than 10%, about 7 to 8% of people die suddenly, say once you've crossed 50, because until the age of 50, you are very likely to be doing risky things like becoming a terrorist or a soldier, or driving rashly, or smoking yourself to a early myocardial infarction, all kinds of things. So once you cross 50, it's presumed that all those risks are significantly less. And to get a sudden death, you have to have a lot of punya, like our long-haired president had. Only 7% of people after the age of 50 die suddenly. The next trajectory is something that peaks in the 60s, when people are around about their 60s, and this is that of malignancy. Now, you know that malignancy, people have a lot of treatments now, and people carry on with first chemotherapy, second chemotherapy, until eventually the tumor burden crosses a certain point, and then they have a fairly predictable trajectory which goes steadily downhill, and it's been called the waterfall trajectory. Cancer accounts for about 20% of all deaths. And this was our former defense minister and the chief minister of Goa, Manohar Parrikar. He died of CA pancreas. Then comes organ failure. So somebody who's entered their 70s with diabetes, hypertension, whatever it is developing heart, lung, kidney failure, and is progressively going downhill. Now, as people go downhill, they enter crisis, go into hospital, come out not as good as before, then go in, then again, and finally are carried off in a crisis. And that is called the looping trajectory. This accounts for about 15% of all deaths. Now, VIPs get transplants, so obviously I had to get the common man here for a picture. And then you have something called frailty. In a certain amount of difference with, say, organ failure, where people's function is already down, in frailty, which means old age, their function is already low, and it keeps dwindling away like this until death happens. And this accounts for about 50% of us, especially people who reach their 80s. So it's called the dwindling trajectory. And I wonder if you remember that Atal Bihari Vajpayee lost the last election in 2004, and he was not really heard of. He had a stroke, we knew that, but he kept on going downhill until finally passed away in 2018. And this accounts for 50% of people. But there's a fifth trajectory that we have begun to realize now happens, and that applies to people who are high functioning and then are hit by a catastrophic event. Now, typically, this is a catastrophic event that affects the brain. So stroke, traumatic brain injury, they decline precipitously, but they're rescued by intensive care, and then they stay at that low level until they pass away. But we now have realized that it even happens with systemic events. And the classic one is fracture neck femur in somebody in their 80s, and then they are hit by this trajectory. So in all these trajectories, remember that the key point is prognosis. And from the time of Hippocrates, prognosis has been understood as being one of the key functions of the physician. For by foreseeing and foretelling in the presence of the sick and explaining the omissions, he will be the more readily believed to be acquainted with the circumstances, so that men will have confidence to entrust themselves to such a physician. Unfortunately, that doesn't apply nowadays because nobody does prognosis. But can we do it? Yes, there is enough by way of statistics, and I'm sure this is a kind of thing that you will probably never have seen. So, if you look at people who are pretty old, and if you put these things together, so say a male patient who needs assistance with all activities of daily living through the day, and this gives 6 months, and on top of that has, say, a metastatic cancer or a rising creatinine or a low albumin, any one of these, what do you get? Anyone who has more than 6 points, the 1-year mortality is more than 60%. So you could say, well, so and so was my uncle and he stayed on to 4 years. Quite right. So 60% in 1 year means that leaves about 60% of the remaining 36. So you can do your calculations, and then 64% of what remains. So effectively, there's a very, very small number who will survive beyond about 3 to 4 years once you identify these criteria. So this means that most deaths can be anticipated, although a minority are unexpected, and that is estimated at about 10%. And if you recognize this decline, then you can give care that confirms to people's wishes, so that more people live and die in the place and in the manner of their choice. And I strongly suggest that you look at Gold Standards Framework. This is an NGO out of the United Kingdom which has done a lot of work in this, and their algorithms are what are used by UK general practitioners. So if we have to recognize terminal illness, we have these 4 triggers. The first is a surprise question. The second is overall indicators of decline. The third is specific clinical indicators related to systems and disease diagnosis. And the fourth is when it is due to a specific decision made by the patient and family. And we look at all of these in detail. Now, the surprise question is simple. Would you be surprised if this patient were to die in the next 1 year? And you say no. Or would you be surprised if this patient would die in a shorter time frame? And again, you say no. Now, this has to be an intuitive answer. It puts together clinical features, comorbidities, social and other factors, so that you get a whole picture of deterioration. And you will be surprised that with experience, for instance, in oncology, people generally reach about an 80% predictable. But I think that most of us, if once we start paying attention to it, can achieve a figure of about 70 to 80%. It's never going to be 100%, but we get up to fairly significant figures. And this is an intuitive thing, and it has been statistically validated. So it's increasingly used in palliative care, the surprise question. Then general indicators of decline. And this is something that needs systematic assessment, but when you look back at it, it seems to be very obvious. So you have an individual whose self-care begins to decline, stays in bed or chair more than 50% of the day, requires more and more help in activities of daily living. And this is something that was not there, say, a few months ago or last year. And it seems to be getting worse. Well, what does that mean? Decline. You can actually put numbers to it. So here you have various scales that I use. I have showed the Barthel index, and you can look this up for yourself. So somebody who's completely bedridden and comatose or barely arousable is at 10%. No symptoms, normal is 100%, like that. And you can combine that with other indicators. One is, of course, comorbidity. So if anybody has multiple chronic illnesses, congestive heart failure with CKD with diabetes. But you would understand that this is more likely to decline. Advanced disease. And that doesn't just mean metastatic disease. It also means somebody whose breathlessness is getting worse. In Parkinson's, I've realized that it could even mean severe constipation to the point of obstipation. That could be a feature of somebody going downhill. Or treatment that does not work. Diabetes not controlled, COPD now requiring home oxygen, and so on. There are some specific indicators that you can actually look for. Progressive weight loss and a surrogate marker, serum albumin that drops below 2.5. Then repeated unplanned or crisis admissions or a sentinel event. And the sentinel event need not be physical. It could be the loss of a spouse of, say, 40, 50 years. And we've heard of these stories often enough. But when you have diseases, then you can use more disease-specific guidelines. Sometimes it helps, sometimes it doesn't. Sometimes even the general indicators work better than the disease-specific. But let me tell you, it's most predictable for cancer. So anybody who has stage 4 disease and multimorbidities, no further treatment. Yeah, as soon as they come to the point that they are spending more than 50% of their time in bed or lying down, the prognosis is estimated to be about 3 months or less. As clear as that. When it comes to organ failure, it tends to become somewhat erratic and unpredictable. For instance, let's look at liver disease. Somebody with hepatocellular carcinoma, liver transplant, advanced cirrhosis, refractory ascites, encephalopathy. Remember, I told you about the looping. Well, they could be carried off in one of those crises, or they could keep on going downhill, and then the general indicators also are a marker. Then we come to neurology. And with neurologic prognosis, it becomes quite complicated because each disease has its own pattern of deterioration. For instance, motor neuron disease behaves almost like malignancy. Once bulbar failure starts, unless somebody plans to go on a ventilator indefinitely, they decline literally like cancer. So once they reach that state, then it is 6 months to a year. Whereas with dementia, people could survive for fairly long periods of time, even after they reached end stage. And this especially happens if they are being fed artificially, and we'll discuss that a little later. So for neurologic decline, what matters is decisional triggers. So if somebody has progressive deterioration in physical and or cognitive function, symptoms which are complex and too difficult to control, or swallowing problems, or even speech problems, and you decide not to pursue life-sustaining treatment, that is where it will end. So it's easy to understand this if you have personalities to go by. This is because we have now the means to keep the body alive indefinitely should we choose to do so. Remember that if you are an Indian VIP, you are condemned to torture before death. If you are an American VIP, then you get to die in your own beds in Darbar. Atal Bihari died on ECMO in the AIMS ICU. He died one day after, he passed away one day after a big man gave a big speech. That was I think the 16th of August in 2018. Lata Mangeshkar, those incomparable vocal cords were raped twice. She had a second intubation and then she died on the ventilator. Anyway, so I'm going to take a short break at this point and ask for any questions if there are any, and then go on to the next lot of slides. Sridevi, anything?
No questions in the chat so far, but if anyone has to ask something, you can unmute and ask at this point.
No?
No.
Okay, let's go on. Okay. So I'm going to show three cases and kind of show you how this works out. So this was a patient who I saw literally at the end of his life. He was, when it started, he was 81 years old. First started to become a little forgetful, diagnosed early dementia, and he had to be treated for mild depression. And he asked his neurologist, "Ab kya hoga? What next?" No answer. Little before that, he had been pretty active, and he had resigned basically from all his responsibilities because he said, "I can't cope and want to take it easy." And he was, like so many of our patients, living with his wife, with his kids in the US. And this was 2014. Through 2015, he maintained an independent daily routine, except that once he got lost in his own neighborhood, his clothes became simpler. And he started to ask his wife the same questions again and again, irritating her. By 2016, he was needing more supervision, came out of the bath naked once, the toilet would be left dirty, and the wife needed to supervise him. By 2017, he started needing prodding for bath and clothes change, and then he would get very angry. And once he got outside the house, but fortunately, the building chowkidar caught him and brought him back. In January 2018, he developed encephalopathy due to UTI. And then a hyperfunctioning detrusor was found. So he eventually ended up with a suprapubic cystostomy, but he could still walk around the house. And his conversation was pretty much limited to yes, no, and things like that. And now his wife asked the neurologist, what will happen next? And was told, well, this is old age. By December of that year, one more episode, this time hyponatremia. And unfortunately, after this time, you can see, I mean, that looping trajectory superimposed on the steady decline. And he became bedbound and nearly mute. So one would have thought that this would be an indicator that things needed to be planned for, but no. In 2019, he came in with recurrent seizures, and although he could have been managed without intubation, he did get intubated. Even though the fits got controlled, there were no fresh changes on the CT. He could be weaned off the ventilator, and for whatever reason, he got a tracheostomy also, with the idea that it would be easier to handle him at home with that. But somewhere around that time, the son came down from the US, and there was a prolonged discussion before the peg could also be placed, and eventually he got discharged for home care. At home, he was completely mute, fetal position. So effectively, he was in the persistent vegetative state due to severe dementia. And palliative care had been involved during the last 2 weeks in the hospital, after the tracheostomy and before the peg. And the US-based son said, why did we not involve palliative care earlier? Eventually, he was managed at home, and our palliative care physician liaised with the family physician, and finally, he had a bad bout of aspiration and was declared dead at home. Somebody needs to be muted. Right. So you can see there were so many missed opportunities. The roadmap ahead was not informed. At the first and the second admission, prognostic information could have been given, goals of care could have been given. Somebody is driving, so you need to mute yourself. We could have started focusing on comfort so that we could have avoided hospitalizations. And maybe he would not even have been admitted for seizures. Was the intubation necessary? Definitely the tracheostomy could have been avoided. It could have been just palliative extubation. We wouldn't have changed the trajectory, but the last stage of his illness could have been cut short by 2 to 3 months. And let me contrast with this other story. This is a patient who's a little younger. Again, living with his wife in Mumbai, gets intermittent constipation, and on colonoscopy turns out to have CA colon, moderately differentiated, and is referred through the family physician to an oncologist and an oncosurgeon. And gets a left hemicolectomy. Post-operatively, there's a discussion with the oncologist where one thing my patient noted was that, well, the doctor spoke to my daughter, he didn't speak to me. So very often when we deal with patients who have terminal illnesses, we avoid looking at them. We avoid talking to them. Anyway, he got chemotherapy, which was well tolerated except one episode of confusion and moderate neuropathy. And what the oncologist did not know is during this period, um, towards the end of it, the US-based grandson identified a palliative care physician in India and made sure that the old man had a consultation there. Subsequently, he had an oncology follow-up, so that it was like palliative care and oncology going together without the oncologist being aware of it. Anyway, in 2017 November, this is the end of the year that he had the diagnosis. A follow-up PET CT picked up extensive metastasis in liver and lungs. Expected survival 4 months. Possible option with targeted therapy with EGFR inhibitors. Possible median survival of 8 to 10 months. Best case 24 months. Our man said, no, thank you. He chose the palliative care option. Palliative care did a home visit and hospice care was set up at home. And look at the last part of the story. In the last months of his life, he had prolonged discussions with his wife. His daughter and grandson participated. The grandson had just graduated and had moved into a new job, but he got 2 months leave to take care of Nana, because he knew. I mean, everybody knew how long there was. And all these discussions happened. By May 2018, he was sinking. Literally, he waited until his daughter came in and slipped away a day or so after she arrived. So think of these two deaths. Cancer death, defined trajectory, prognosis, admissions avoided, and if there is transparency, patient and family retain control. In neurology, the trajectory will be erratic or prolonged. Recurrent admissions may be unavoidable. There is an early loss of personhood. So Mr. AZ versus Mr. CA. Mr. AZ no longer had control. And very often, avoidable ICU care at the very end is a standard feature if you don't prepare for it. But these are two specific diagnoses, terminal diagnosis. What is the diagnosis of old age? Remember that human life expectancy biologically is not expected to increase much beyond 80 years. The occasional individuals who go on into 100, 110, forget about it. 80 to 90 is where we can plan. And you also have to understand the concept of chronologic age versus biologic age. So you will often see these individuals who look 60 but are 80 and vice versa. So you have to look at people's basic biologic health. And you have to also take into account the importance of sentinel events. Somebody who's very fit in the early 80s will not be able to take a major illness, even if they are biologically very fit. So this last case, 80 years old when the story starts, and in 2014, she moved to live near and be supported by her only daughter because she had poorly controlled diabetes, spells of hypoglycemia and DKA. Otherwise, she was normal. And her daughter said, I can't handle you in Mumbai. You have to come and stay next to me. So she settled into her new home. The daughter now insisted on servants at home. She had no exercise, but an active social life. And things went along well till about little over 1.5 years, when she had a febrile diarrhea illness, where actually she needed admission to the ICU, but was quickly discharged. But soon enough after that, 6 months later, she fell at home, developed a fracture left neck femur, hip replacement, post-op delirium, but recovered well, and she was walking with a walker at 3 months. So then in March 2017, the next year, her husband actually developed lobar pneumonia. He had crossed 90 by then. And uh, I mean, although the lobar pneumonia was very clear when he was admitted, for 3 days he had only vague chest pain and just collapsed, and before you knew it, multi-organ failure. And uh, as it turned out, DNI was confirmed by his wife, and he passed away 48 hours after admission. And this had happened because soon after her admissions, both husband and wife had spoken to their daughter and made it clear that there were going to be no heroic measures for either of them. In fact, both of them wanted their bodies donated to the medical college. And the granddaughter moved in to live with her, and she was, well, she was really happy. But beginning of the next year, she started to develop multiple superficial soft tissue abscesses. Twice this was treated with intravenous antibiotics, cultures uh, obtained, but the the infections just wouldn't heal. So she was discharged for home care with daily dressings, and she asked, what is happening to me? And she was told the medicines are not working, we have to manage with the dressings. And she said very clearly, okay, then I don't want to go to hospital again. And she refused any painkillers stronger than paracetamol. So this was March 2018. By end April, her activities started to go down. She needed help with all basic activities of daily living except eating, and her appetite started to go down. Second week of June, so March to June, about 3 months, she started to become confused, a little restless. She seemed to have pain even on turning over in bed. Her vitals started to decline. And a little after this was noted, 3 days later, one day, she stopped speaking and she stopped breathing later the same day and was gone. So, if you look at it, having understood the concept of the trajectories, you cannot say that we cannot foresee and foretell death. It's not possible. Now, why on earth is it that we don't do this? And I'll come back to this. Remember that before the middle of the 20th century, diagnosis, therapeutics, and prognosis were three equally important functions of the physician. But as medical treatments and diagnosis improved, the skill of prognosis declined in teaching, in research, and in practice. And when you prognosticate, you have to combine foreseeing and foretelling. Now, you could say that foreseeing is something that, well, is a scientific function. Foretelling is a soft skill. It has to combine honesty, accuracy, and optimism using communication skills. Why do I insist on these 3 points? You see, in days gone by, in the time of Hippocrates, the doctor could say, so and so will die in 2 weeks. And nobody would question him. People, would actually go home and die. When we are patients, and our patients are empowered. So we want to know why. We want to talk about this. So that's why the honesty, that's why the need for accuracy, and you have to combine it with optimism. So to do all of this, you need communication skills. It's also important to understand that if you do not commit to foretelling, your foresight will atrophy, because you have to look at these two as one single function. When you talk to families and patients at the end of life, what do you talk about? In addition to telling them what is to happen, that is not enough. You have to tell them what can be done. So the first is goals of care. So you combine this as you do prognosis, you combine this with patient education, and you explore and elaborate this with patient and family. And this is something that is included in our normal discussion. This comes to a point where the goals of care come into a system for documenting this information and making it actionable. And this includes choosing a proxy decision maker for the end of life. Ideally, this has to be legally valid and backed by public policy. This means living wills. And we'll talk about this at the end of the lecture. And when you do all of this, then you make decisions together with the patient and the family, combining clinician input with patient or family input so that you make appropriate in the moment decisions. As the situation comes up, you are prepared to make decisions. So when you set goals of care, the first is you have to find out how much they understand. You also have to ask how much they want to know. If somebody says, just take care of me, don't tell me anything more, fair enough. We have to explain the uncertainty that we are dealing with. But probably I find the most useful is to find out the patient's wishes about place of care. And does the caregiver agree? Are they going to be able to manage? So there are times when very often people want to pass away at home, but the family says we can't handle it. And remember, these wishes and plans may change over time. If you do it well, then it improves the patient's quality of life because they get a sense of control over the last days. It reduces the stress, anxiety, burden, conflict in surviving family. And the system is not overburdened with unwanted intensive medical interventions and hospitalizations and CPR at the end of life. When Atal Bihari Vajpayee passed away after 10 or 15 days, you don't think there were patients who were turned away because they could use ECMO on somebody else? So think of that. So challenges. From the patient side, it's fear of death. Difficult to think or talk about end of life issues. For the clinician, it's lack of time. But most importantly, I think it's difficulty discussing prognosis. So as I said, the first decision is place of care. The second is mode of feeding when the patient is unable to feed. And then parenteral medications other than those required for symptom control, and life-saving treatments that you will or will not accept. So CPR is a procedure. You can say no to it. Ventilation, yes, everybody knows about ventilation. So also about dialysis. But even IV antibiotics, even RT is a life-saving treatment and can be declined. Now, we don't discuss this because, well, families don't see the timeline of decline. And you can see this in my last patient. Once this had happened, we were in a terminal illness. And here is where the decline had begun. And this is where she had come to active die. So we'll look at how to identify this clinically. So families, as I said, do not see the timeline of decline. Clinicians do not see it or see it and ignore it, and almost always don't know how to handle it. But remember that if you do not know how to foretell, even your foresight will atrophy. And I think that is a failure as significant as poor diagnostic skill. Now, communicating this takes communication skills. It's a learned skill. Surgery is a learned skill. Diagnosis is a learned skill. So when you get a learned skill, you're trained. You need a mentor. You need to be supervised when you start. You need to practice and reflect on whatever you have done. You need assessment and certification. And then the guru actually goes through each of these as a procedure, preparing for the procedure, going through the procedure, and reviewing and reflecting on the procedure. So remember that comm skills are no less mentally than a surgical skill. Unfortunately, whenever I try to explain to my senior colleagues that they need communication skills, their response is, "Apne baap ko samjhayega." So that's where it stops. Remember, all of us have rights at the end of life. These rights are to be treated as a living human being until death with a sense of hopefulness, however changing it may be. At the end, it may just be a hope that there will be no pain. To participate in decisions concerning your care and to have your questions answered honestly. And even if your goals are changed from cure to care, you expect continuing attention. To die in peace and dignity without pain and not alone. To retain individuality and not to be judged for your decisions that you make. After that, to expect that the sanctity of your body will be respected and at all times to be cared for by caring, sensitive, knowledgeable people who will attempt to understand your needs. You can look this up. And I'm going to again stop because this is another break point, because we are now coming into the clinical part of handling death and dying. Questions? Let me also look at the chat.
Nothing in the chat, but if someone wants to ask before we move on.
No.
No.
Okay. So, well, dying is a physiological event. It's a philosophical event. It's multiple things, but we are doctors. So let's look at it as a clinical event. How do we know when a person is dying? And these are purely clinical signs and symptoms. Now, what I'm telling you from now on is best applicable to cancer, because as you remember, in cancer, once the tumor burden crosses a certain point, then you have the defined trajectory. But if you remember, even my the old lady who died literally of just old age and diabetes also had that same trajectory. So when we look at active dying, these are the hours or days preceding death, during which time the patient's physiological functions wane. And the important thing is to prepare the family for the natural process of dying. The care has to be multidisciplinary and holistic, and it has to extend to after death care and bereavement support as well. So months to weeks before death, this is called pre-active dying. The predominant features are physical and psychosocial withdrawal. If you remember the general indicators of decline that I pointed out: decreased ambulation, weight loss, occasional incontinence, decreased intake, but also withdrawal from family and friends. There's not the energy, and there is perhaps the understanding that things are now coming to an end. When active dying begins, the key feature is affection of the brain, delirium. So they fluctuate in and out of confusion. During this period, the vitals tend to decline, drowsiness increases, incontinence happens, and the person becomes confined to bed. And this happens weeks to days before death. And what happens at the last stage? Days to hours before death are deteriorating vital signs. Death is now imminent. Uh, Consciousness goes down, breathing becomes irregular. The death rattle, where secretions get pooled. Very often we control this in practice, so it may not, because families often get bothered by it. Hemodynamic changes, face may relax, the face becomes yellow and sallow. And for me, one of the signs that I I point out to my residents as well is when people start to move the mandible during breathing. This is gasping. And if you see that happening, then the mandible is also moving in respiration. Yeah, you know that you're close to the end. So the goals of care now become to ensure the patient's comfort, see that the end of life is peaceful and dignified, and make the memory of the dying process as positive as possible for the carers. So your symptom management has to focus on comfort. The drugs have to be reduced to the bare minimum that are actually required, and you have to manage refractory symptoms. So the first challenge is nutrition and hydration. Now, the person has no appetite, aversion to food, nauseated, may have stomatitis. If there's candida, obviously you have to treat it. So what can you do? Well, what you should not do is put in a feeding tube, because feeding tubes do not enhance survival or quality of life at the end. They are associated with agitation. You need to tie patients down, and then they get pressure ulcers, and they do not reduce the risk of aspiration or pneumonia. So that's why, although they prolong life, the quality of life is significantly hampered. And that is why overall, and they do not make for somebody to survive. So these decisions have to be reviewed and made well in advance. If there is a feeding tube in place, then you review rate, volume, route according, so that you avoid complications relating to overhydration. This is because as the body is shutting down, the requirement of fluid drops. Anything more than a liter is likely to leave the person all bloated up, and you need to avoid that. So what can you do? The best is to do careful hand feeding, normal food, mashed, whatever the patient likes. You may use nutritional supplements, but that's unnecessary. And thirst can be alleviated by good mouth care and ice in the mouth, with the lips being kept moist and lubricated. So remember that the total fluid requirement is about 1 liter per day. What I do is ask if the patient is passing urine 3 to 4 times per day. Once, as long as they are doing this, this is maintained. Once they drop below this, then you know that things are going down. We avoid rice tube, we avoid IV fluids, and we just ask the family to hand feed. And it's actually a sense of comfort for everybody. What about medicines? You stop all medicines that are not required for symptom control. Only a few medicines need to be continued. IV antibiotics, aspirin, statins. Statins are meant for a prognosis of 10 to 15 years. What is the point in giving them when it's down to days? So also vitamin supplements. Sugars tend to decline. You can monitor them and give insulin SOS, but both insulin, regular insulin and oral hypoglycemic medications need to stop. Other psychotropic medicines all need to come off. Now, the symptoms that bother the patient and family are, first of all, pain, agitation, and then, of course, incontinence, dyspnea, nausea, vomiting. Individual patients will have individual combination of symptoms, and you have to tackle whatever is affects that patient. When you want to give end-of-life medications, remember that you're not going to have an IV line. So the subcute route is probably the best, but you can also give it sublingually, transdermally, rectally, intranasally, and so on. And sorry. And for most of palliative care, subcutaneous is probably the route to go. Just give me a minute. Yeah. Right. So pain is the most common symptom, and you need to anticipate and treat effectively. I'm sure you've been taught quite a bit on opioids and so on. So I'm not going to do much more on this. What about restlessness, agitation, delirium? First of all, look at the patient's environment and try non-pharmacologic measures. Always check urinary retention and constipation. Pain. The patient may be grimacing and not speaking. You have to look for sites of pain. If there is retention, this is one of the few interventions that we always perform, and that is to put in a urinary catheter. If there is constipation, it's worth taking the trouble of doing a manual evacuation. It really relieves patients towards there. Medicines which are unnecessary, especially anticholinergics, need to stop. You need to increase natural light, put on glasses. If they can be moved, mobilized in whatever fashion, whatever time there is, if it is safe, do it. Remove all kinds of lines, stop stimulating noise, put familiar objects in the room with the patient, let them sleep at night, and be careful how you talk to them. Don't shout at them. If at all pharmacological interventions are required, haloperidol is the treatment of choice. How much? Well, we can go up to substantial doses, but typically I find that 1.5, say 1.25 or 2.5 milligrams 3 times a day for maybe a day, and then quickly drop down to 0.5 TDS and maybe down to even 0.25 TDS works. And once patients are quietened, then you can come down to 0.25 or 0.5 HS. But there is no harm in giving more if it is required. Benzodiazepines should be avoided. If they are breathless, there are 4 principles of managing breathlessness. First is correct the correctable. So if there's pleural effusion, then do a pleurocentesis. Air movement on the fan improves symptoms, so use a fan on the face. And then you reduce the perception of dyspnea by using morphine and anxiolytics. And if there is no recourse, then you use what is termed palliative sedation, and we'll talk about that. Similarly, with nausea and vomiting, you start with reversing the reversible. So constipation, hypokalemia, hypocalcemia, these are the big 3 that need to be identified and tackled. The first line drugs that we use are metoclopramide haloperidol and ondansetron. Haloperidol is also used as an antiemetic. If that doesn't work, then you can use steroids and even lorazepam. And eventually, cyclizine, I don't think I've ever used, but olanzapine can be used once in a while. When the secretions accumulate in the throat, they produce what is called the death rattle. Noisy breathing in 50% of patients is a predictor of death. And this happens either because swallowing reflexes are inhibited, so saliva is accumulating, or bronchial secretions are accumulating just below the larynx and causing. And you have to tell the family that this is not causing any distress to the patient because the patient is now out of it. Management can be non-pharmacological, so repositioning, and you remove the secretions from the angle of the mouth using a finger wrapped in gauze piece. What we do not do is suctioning because it's very uncomfortable. If need be, use pharmacological control with glycopyrrolate and hyoscine. Typically, glycopyrrolate is the most commonly used agent in our unit. Other nursing interventions that are important are mouth care, pressure sore prevention. Again, simple measures. Ideally, a waterbed or an airbed is very useful. And as I said, catheterization and monitoring for constipation are important. And then you prepare for the end. And in most patients, it is simple. The patient stops breathing and the heartbeat stops. But there are two dramatic possibilities. The first is in neurology cases and occasionally in other illnesses also, epileptic seizures. Now, one thing that you do is do not force objects into the mouth to prevent the tongue being bitten and so on, because by the time the fit starts, if the tongue has to be bitten, it is bitten. You don't give any oral medication. You have to have subcutaneous midazolam or an anti-epileptic drug available. And if it is really terminal, you just use sedation, because the patient will gradually become unconscious, quiet, and will stop moving because the limbs get exhausted and the discharges are continuing inside the brain, and eventually the brain fails and stops. But the even more dramatic one is the blowout hemorrhage. This is with oral malignancy, which starts to infiltrate the neck arteries. And this is one possibility that must be discussed in advance with the caregivers, because this can be really dramatic. So bleeding will stop. It's not a blowout as though like a fountain of blood, but once bleeding starts, lots of blood starts to come out fairly quickly. So what you do is apply steady pressure with dark towels, preferably green, because then it doesn't show blood, it doesn't show bright red, and sedate the patient quickly. Now, this is a palliative emergency. At this time, you have to stay with the patient until it is over. What if somebody is having refractory symptoms which just are not getting controlled? So we have this concept of using palliative sedation. And on the other side, we have this concept of euthanasia. When you use palliative sedation, you're giving them proportionate sedation to make the patient sleep while the natural process continues. And you are not affecting the sanctity of life in any way. Of course, your sedation may hasten death. That's called the doctrine of double effect, that your intent was good, but this happened. As opposed to euthanasia, where you actually relieve suffering by terminating life, the intent is to terminate life. The natural process is taken over and in fact stopped. There is probably no sanctity of life here, and death is actively accelerated. So palliative sedation is something that palliative care physicians have to be prepared for. Remember, through this, the family may be suffering as much and maybe even more than the patient. So you have to address the social, spiritual, and religious needs. And if need be, you involve a palliative care team. When death occurs, introduce yourself, and if you're supposed to be confirming death at home, start by introducing yourself, wash your hands, confirm identity, be sure to watch for signs of life, feel for the pulse. Once you're sure, give it at least 3 minutes to auscultate for heart breath sounds. And once this is done, then you exit and see that documentation is complete. After that, you do need to go back and visit the family for bereavement support. And palliative care units dealing with, say, malignancy need to collect back unused opioids. And then you explain what is coming. So grief, normal grief lasts up to 6 months, and it is a wave-like character. So there'll be days when they'll be completely knocked off by the grief, and then life comes back to normal. And these waves will be very severe in the beginning, and gradually they settle down. And they need to know that this will take its own time. But the most important is to start off by supporting the family before death occurs. Anticipatory guidance helps because you prepare them by explaining what is likely to happen. You have to be available to answer all questions. And as far as possible, you should fulfill the wishes of the family using extra help, enlisting medical teams in the community, and so on. Remember that bereavement is a period during which mourning and grief occurs. Grief is the natural distress. Mourning is the outward expression of that distress. And remember that before somebody actually passes away, they will have had many previous losses. And everybody experiences grief uniquely depending on their culture, the nature of loss, and the relationship to the deceased. Types of grief, well, you can have grief before, that's anticipatory. But the main ones that we recognize are acute, integrated, and complicated. Acute is the natural one that occurs immediately. Integrated is when those waves get assimilated into your daily life and understanding. But complicated is when the grief response persists for an extended period of time, and we take anywhere. For me, for clinical purposes, it's effectively 6 months, though people have labeled it as even up to 12 months. Remember that we are supposed to continue bereavement support at least for a year. We are supposed to identify caregivers who are at risk of complicated grief, and you have to refer them appropriately. And bereavement support group meetings can be held. So the key messages are that terminal illness can be identified. Focus has to shift to symptom control, comfort, and quality of life. The active dying phase must be recognized and the family must be prepared. And family support begins before death and continues afterwards. The last part is, well, what can you and I do about it, and what is the legal status? So I'm again going to take a bit of a break and ask for questions before I go on to the last segment.
Yeah, there is a question in chat. If the patient's antibiotics are stopped, aren't we hastening the death as there is a chance of increased infection can lead to sepsis and septic shock?
Okay, so what do you think is active dying? Does anybody know what active dying is? Active dying is the body's immune system shutting down and bacteremia spreading through the body. So you have reached a stage where antibiotics are absolutely not going to work. So all that you're doing is you have to maintain an IV line, you have to inject the patient, cause pain. No. So again, we come back to the same issue. Once you have recognized the trajectory, then it becomes fairly clear-cut. If you have not recognized the trajectory, then obviously you will be giving antibiotics and so on. Right. Anybody else?
So you were talking about discontinuing the medications, like especially the patient, say for example, has stopped taking foods orally, and is on oral hypoglycemic agents and antihypertensives. I have noticed that some of the doctors, the physicians, the general physicians, don't really advise stopping the medicines. So how do we decide in such cases? Who makes the decision? Because the family is usually conflicted.
No. I mean, if presuming that you've been through this course, you are going to be making these decisions. And once you have gone through these discussions with the family, you know the diagnosis, you know that it is in the terminal stages, then these are actual decisions that you take. That so for instance, you look at antihypertensives, the vitals are declining. What good is an antihypertensive going to do when your regular systolic is 100 or 110? What is the point? If you monitor their sugars, you'll see that their sugars actually start declining. They're not taking in anything, and whatever they're taking is being consumed by the sepsis. So again, the sugars are declining. And this is clinical understanding, experience that palliative care units have. But this is something that if you monitor very carefully, you'll see that this is more than 90% of times this is it. If the sugars are 500 plus, then you are dealing with, well, a diabetic emergency, not unlikely to be the end of life. And you still have the target of treating that. So typically you will see that all these numbers start to decline. And whether it is a feeding tube also, we call it clinically assisted nutrition and hydration. That is taken as life-sustaining treatment, which patients are entitled to refuse. That is their right.
Yes,
Okay,
Dr. Shrikant, there is one more question. Dr. Shrikant?
Go ahead, go ahead.
Thank you, sir, for your very riveting, clear, and insightful presentation. I have one question. With telemedicine being, the scope of telemedicine has expanded, can the process of active dying be facilitated through telemedicine? And then apart from the certification aspects? So
I don't think so. I think this is one of those things where the physical contact is still essential, because there's a limit to how much you can take it. But I have been through this once, and this was right at the beginning of the pandemic. I think towards the end of the first severe lockdown, where I had never seen this patient, and the family gave me the history of dementia that had been going on, and the patient had become bedridden. And there was a family doctor who was willing to make a home visit. So between the two of us, we did manage to let the old man pass on peacefully. But I would not leave this to telemedicine. I mean, somebody's seen the patient, made the prognosis, figured out the dying process. Yes, then after that, then you can manage by phone. Then the palliative care team can manage by phone, but we still do require, I mean, we still prefer a personal touch as far as possible.
Thank you, sir.
Yeah, Vanita.
Sir, this is a hypothetical case. Suppose we have a 40-year-old patient who has had a traumatic paraplegia, sir, and he comes.
Okay.
He has had multiple episodes of UTI and has also developed obstructive uropathy and is having CKD also now. And he comes with a urosepsis, sir. Then, at that admission, how do we know whether it is terminal care, whether we should aggressively manage the sepsis now? Because it may not be a terminal event for this patient. He may still recover and get back, but though the things may not be completely reversible, like his paraplegia is not going to get reversed, his CKD is not going to get reversed, but this episode of sepsis maybe can be managed, and he might it may not be a terminal event for him, sir. So in that case, how do we decide? Should we discuss with the family?
Yeah, the first most important thing is you don't decide. It's the patient who decides. If somebody is paraplegic, then they should have been spoken to about long-term prognosis and so on. And it's quite possible at some stage the patient may say, enough. That is one. But that has to be documented, recorded, everything. Obviously, if the patient comes in an acute situation, I would always treat. There's no question of not treating. People with paraplegia can have fairly fulfilling lives. And in our situation, they end up having disastrous lives, not because they can't be managed, but because, well, we are not able to put the systemic supports in place that should take care of them. So in this case, no, I would obviously treat.
Thank you, sir. Unless
the patient has very clearly stated that my next episode of sepsis will be my last. And people do that.
Thank you, sir.
Okay, sure. Let's move on. Now, why do we shy away from these issues? And if you look at it, if you ask families who've been through this, what civil society says, they say these are perverse incentives. You want to keep earning from these patients. In fact, one joke that I have about corporate hospitals, there's a disclaimer, Hinduja Hospital is a trust hospital, it's not a corporate hospital. So corporate hospitals are those where the poor cannot enter and the rich cannot leave. So, and civil society thinks that we are actually making money out of this. But what doctors feel is that, well, there is no legal clarity. One is there are no requirements that we should do this, because unless there's a law which says you will be punished, thou shalt not, on pain of, well, why should I bother? On the flip side, there is the fear of criminal charges and litigation, and I will answer that. Meaning, if you do the right thing, then you could be charged with committing a criminal act, and that is actually very wrong. But actually, what I think we lack is, one is the basic difficulties in establishing prognosis, because we are not trained in doing that. It's not part of our general medical education, and we have no capacity in or skills in palliative care, end of life care, and communication skills. Because we don't have that, well, we actually, these are situations we just can't handle. Remember that from the 50s onwards, as medical progress happened, antibiotics happened, ICU care happened, organ transplant happened, survival became ubiquitous. So people went into ICUs and actually came out walking. But this also meant that some people would not, and death became medicalized. Instead of dying at home, which was the norm, till the 50s and 60s, people started to die only in ICUs and hospitals. But simultaneously, medical paternalism was ending. Informed consent, patient autonomy and rights began to be written about. In fact, the living will was first written up by a human rights lawyer in the US. And because the US, various states, there were patients' movements and the politicians caught on, the USA became the world's laboratory. It was effectively as though each state competed against the others. On the other side, this was individual rights. On the other side, from the United Kingdom, palliative care was designed as an intersectional specialty, which meant it came across specialties and it began to spread from the other side. So across the developed countries, the understanding of patients' rights and palliative care both rose simultaneously. Remember that there are 4 pillars of ethics: autonomy, beneficence, non-maleficence, and justice. You also have to look at empathy, compassion, fidelity, integrity, put it together with dignity and honesty. Think of it. You have all of this to take into account. Now, how do you put it into a given clinical context? If any of you is interested, try and look up this book. It's also available on Kindle. So they outline a 4-box model. The 4 boxes are: first is medical indications, which combines beneficence and non-maleficence. The next is patient preference, where you respect autonomy. The next is quality of life, where you actually combine autonomy, beneficence, non-maleficence. And contextual features means you put it in the context of justice for others who are not there. So for us, the legal framework for all of this obviously starts off from the Constitution of India. And because we follow the common law system, our laws are, so situations are interpreted by judges and lawyers based on this constitution, and that gradually over a time becomes law. The only specific act that we have is the Organ Transplant Act. So we have Supreme Court judgments. They do rely on professional guidelines, and then we have these other acts, the Penal Code, Mental Health Care, Consumer Protection, and Registration of Births and Deaths Act. I have been involved with this whole issue since March 2011 because I was involved in the Aruna Shanbag case. And remember that it was in 2011 that the Supreme Court effectively decriminalized this kind of decision making. You know that we cannot have FIRs filed against us. And more so, of course, when these are specific ethical decisions at the end of life. This judgment also dealt with patients being kept alive mechanically, including brain death, and they said withdrawal of support was permissible. Of course, for Aruna Shanbag herself, they confirmed that she was not brain dead, and since her next of kin were the nurses of KEM hospital, they said let her be. But they prescribed a fairly impractical procedure. And in March 2018 was the final judgment on this. Of course, there's more that is happening, but this was the main judgment that came out in 2018. What did it say? It said this very, very clearly for the first time in our history. All adults with the capacity to consent have the right of self-determination and autonomy. A competent person who has come of age has the right to refuse specific treatment or all treatment or opt for an alternative treatment, even if such a decision entails a risk of death. The emergency principle can be given effect to only when it is not practical to obtain the patient's consent and his or her life is in danger. But where a patient has already specified that he or she does not wish to be treated, then that has to be accepted. And when you look at this, remember that this was a judgment that was based, as they called it, constitutional morality. Constitutional morality and ethics to some extent go together with that. In a sense, the Indian Constitution is our ethics workbook for running this country. And obviously laws have to be in consonance with that. But laws and judgments also take into account what people do. And especially when it comes to doctors, they do have to follow what we do when we make guidelines and policies. Now, what do we have? We have guidelines for the end of life care. There's an integrated plan for the dying from the Indian Society of Critical Care Medicine and Palliative Care. But this was before the judgment. After the judgment, these documents have come out. Now, let me point them out to you because I was involved with at least 3 of them. The first of this was a living will sample that we worked together, and this is available on the Pallium India website. I'll show this to you. Then the Manipal group of hospitals, starting with KMC Manipal, put together something called Blue Maple, which is in a sense a private document, but which they use for guiding, making these decisions. Then came out 2 documents, one from the ICMR, which looked at do not attempt resuscitation. Remember that I told you CPR is a procedure. If you think it is going to be required, it is good practice to ask for permission to perform it. And if it is refused, then do not perform it. AIMS Delhi actually put out a whole bunch of instructions. So on the public side, you have the AIMS guidelines. On the private side, you have Blue Maple. They're different, but they overlap quite a bit. This is more elaborate, this is less elaborate. And I suggest that you look at this in case you want forms and so on to actually go through with this. So how do we perform this process? Ideally, this should be backed by hospital policy. Once medical futility is identified in the hospital, make sure that there is a consensus on futility amongst the involved consultants. Make sure that the family has consensus. If the patient is competent, then the patient has the first right. If the patient has an advanced medical directive or living will, then that is next. The last is the surrogates. And you have to confirm that you have appropriate surrogates. So the hierarchy of surrogates says what. Once you do this, you document this, and this has to be signed off by appropriate surrogates. And at least we insist on 3 consultants, the primary and another 2, signing off on this. And ideally, the whole process should undergo post facto audit, meaning audit after the whole process is over and done with. Sorry, this photo has appeared again. That's Aruna Shanbag. And this is a sample of the living will. I'm not going to go into the details of this, except that this is available on the Pallium India website, on Vidhi Legal Policy, our legal partners, and the Indian Association of Palliative Care website. So if you need to make this or you suggest this, then it has to begin by speaking to those close to you, because a surrogate or a healthcare power of attorney has to be chosen, and they have to accept the responsibility and understand your wishes. And then when you make the advanced medical directive, it has to be signed in front of two witnesses. Ideally, this has to be attested by a judicial magistrate first class. Now, that is something that is quite difficult, and we are working at it. But up till this point, it is completely in your hands. Anybody who does it, provided it is supported by the family, this is valid and effective. It is not enforceable because, well, any doctor can say, sorry, this was not signed off by JMC, I'm not going to listen to this. But if the family stands by it, then it is valid. And I recommend to my patients that you have to show it to every doctor you consult, because you'll find out if the doctor is willing to accept it and support it, will be able to find out the hospital's policy so that you know where to get admitted. And well, the doctor will know your wishes. I'm going to stop at this point. We still have enough time, and I'm happy to take questions again. If anybody, you will of course get this presentation, but if anybody runs into issues where clinical questions come up, I'm happy to take emails and even WhatsApps on that. Thank you.
So I'm Dr. Shetty here.
Yep, just a minute. Let me close this and come out.
Yes.
Yep, here we are.
So actually, this discussion is the need of the hour, that I would
Thank
like to say, because now, as you said, death may be due to old age or maybe due to disease, but ultimately we have to go through these stages, sir. So here the main point is the challenges you are talking about. Why that for the clinicians? What I feel that the main challenges, there is no relation between patient and patient family and the doctors. So now in Indian scenario, what I opted, like more than I need palliative care definitely, but in between we would like to have a family physician concept, so that at least somebody should be there to guide always. Going to a medical college, and I don't think no clinicians will have time or patience to guide a patients for a long time, especially for the chronic patients. So these sort of cases, what steps we can take, sir, as a palliative care or a care physician? Definitely, if there would have been any family physician, we can discuss with the matter and we can guide them. Getting from super specialty doctors to palliative care, it's impossible in India, I think.
No, I don't really agree on that.
Okay.
So one is that all of us need to be aware, right? And wherever we are involved, as long as, see, once you understand trajectories, once you understand prognosis, once you understand how to give prognostic information and support, a lot of stuff is achieved. If you know how to handle symptoms, there's a lot that you can do even without being there. So we spoke about telemedicine for literally the last hours and days. Yeah, that is difficult, but till that point, I've handled a patient who died with a massive tumor who I never saw somewhere in Mysore, because there was a palliative physician there and I was kind of consulting them purely on telemedicine. So a lot can be done provided we are prepared, right? So remember that this is not a job that 100% of our colleagues are going to take up or accept. If you think that this is something that matters to you, you do it, right? And again, I understand family physicians are a dying breed all across the country. We don't have them. So establish a liaison with a palliative physician or a palliative unit close to you. All your patients will not be able to go there, but once you and they work together, you will find a lot can be done. Yeah, so I think the most important thing is for us to become aware and start moving on this path. Anybody else?
Yeah, there is a question.
But thank you for that comment. Yeah.
About re-explain the procedure for living will.
Okay. You want me to share it and go through it quickly? I skipped over those slides. Okay. I'll just run over it quickly. Then Um, it's actually a full 1 hour presentation. So if anybody is interested and you check on YouTube, you will get it. Okay, so this was a living will that under Dr. Rajgopal's directions, this was something that had already been made at Pallium, and then we kind of refined it after the 2018 judgment, so that we kind of made it on the basis of that. It has to be an adult. Basically, it comes into effect when the patient can no longer take part in the decision making. And three conditions have to be, any one of three conditions can be met. Terminal illness with no reasonable expectation of regaining consciousness. Terminal disease state where there's no reasonable expectation of recovering with an acceptable quality of life, or persistent vegetative state. At that stage, this obviously applies to somebody who's in hospital. A panel of 3 doctors should be constituted, and if any or all of the 3 situations above are confirmed, then any life-sustaining treatment as listed below must be removed. And you can either tick these or cross these out or tick all of them, whatever. So there are other wishes that people write, and that is that if my family is not present, then please continue this until they can come and see me. Or as far as possible, I would like to be at home. So we keep this space for free free writing. Then to secure compliance with this declaration and or to make medical decisions, I hereby appoint the following as my surrogate decision makers. And you make a list of 3. They are not a committee. They of course can confer amongst each other, but it means that number 1 takes the decision. If number 1 is not there, then number 2 takes the decision, then number 3. So you can't depend on only one person. And you have the option of both of these, or you can cut out to make medical decisions. So all that the surrogate decision maker has to do is make sure that there is compliance with my declaration, right? So that's a point that people often miss. And this remains in force until I revoke it at any time. And the important thing to understand is that the living will can be revoked orally. So if a person is conscious and has a living will, then it is necessary to ask them whether they want to continue with it. And there have been situations where people have been delirious and have said, no, I don't want it, and then regretted it. But that's part of it. It's understood that the living will can be revoked orally, but can only be made by writing. Right. So it needs 2 witnesses. Across the world, every state, every country has its own thing. Some people require only 1 witness. Some people require a notary. It's only in India that we require an appropriate authority, which is a judicial magistrate first class. So my suggestion to anybody here from any state is that what we do want is people to actually approach judicial magistrates. Typically, you'll find that the JMFC says, I have no orders. And it's a bit of public spirit. File a writ petition asking the High Court to give directions to the judicial magistrate to actually start countersigning them. We are doing it in Maharashtra, we are doing it in some other states. But until this process gets simplified, that's all that we can do. But as I said, making this and making sure that the family is aware of it is 80% of the job. Right.
So I have 2 questions on this. The signatures of the witness, the surrogate decision makers do not have to sign on any.
So ideally, the surrogate decision maker should just confirm, but they should not be the signing. I mean, they are not witnesses. Huh?
The second being, sir, when it's time to make the decision, is it mandatory for the surrogate decision maker to be present there? Like in case if it's a son or the daughter and it's he or she is not in the city. So is a presence required or by him?
So ideally across the world, these situations do arise. So ideally, if not the first, the second, one of the decision surrogates has to be physically present. But we've run into situations like this where the third surrogate is there, and the first and the second confirm by either email or phone. I've had that, and we accept it. But you have to do due diligence. I mean, we are going into the process of withdrawal. You have to do due diligence and make sure that the family is covered. You don't ask, and suddenly a fifth son pops up from the US and says, "You killed my mother with my elder brother." Yeah, I mean, that's when people have not done their due diligence.
Yes, Dr. Anita.
Sir, is it, I mean, when the patient declares, I mean, makes the living will when the patient is of sound mind? I mean, that is
Correct.
the first thing. So that is it sufficient that the patient declares he's of sound mind, like some neurological diseases, or is somebody can contest later that patient was probably not in his actual state of mind when he had prepared this will, or he was forced by, like as you said, one son can say that the other son had probably got it. So would
I
certify that the patient is actually of sound mind at that state?
to some extent, I think that you have to accept that witnesses and so on will all probably account for issues here. But I personally feel that anybody who can sign and can sign legibly and the signature can will generally have been accepted to be of sound mind. So neurological illnesses, in any case, advanced care planning becomes very, very tricky unless you do it very, very early in the course. For almost all, I mean, if you look at cancer or anything else, people would, if there is a doubt, but it doesn't have the kind of requirement that you have for declaring sound mind that the estate will has. Estate will has it.
Yes.
But the living will doesn't have that requirement anywhere in the world.
Thank you, sir.
I have a question. Like, we had one case presentation to go from Dr.
Yeah,
Anita.
please go ahead. Go ahead.
Dr. Anita, would you are the questions answered, or what do you want to do? You want to go ahead with the presentation, or?
I think let's finish the presentation and then come back. Now, if they have, I don't mind hanging on for a little while more. If there are questions.
We'll start that. We'll take up the other questions after that. Yes, Dr. Anita.
Good evening, everybody. I'll be presenting a case now. Next slide, please. This is of a 23-year-old male patient who was diagnosed with glioblastoma multiforme. He's post-surgery, post-radiation, and with radiation necrosis. Next slide. Now, the presenting complaints were a 23-year-old male who started having headaches and aggressive behavior since the last 2 weeks. He was brought to the hospital following an episode of seizures and was in post-ictal state. Next. The history of illness: he was a known case of right frontal glioblastoma multiforme, which was diagnosed about 8 months ago. He presented with headache and loss of consciousness. A craniotomy and tumor decompression was done, and the perioperative course was uneventful. He received radiotherapy post-operatively and was doing well for the past 6 months. He developed frequent headaches and aggressive behavior since the last 2 weeks and was brought to hospital following an episode of generalized tonic-clonic seizures and was in post-ictal state. On examination, patient was E3, V4, M6 drowsy. His heart rate was about 108 beats per minute. His blood pressure was 126 by 78 millimeters of mercury in right upper limb supine position, and respiratory rate was 22 breaths per minute. And his temperature was 99 degrees Fahrenheit. Saturation was 100% with oxygen via face mask at 5 liters per minute. His pupils were bilaterally equal, reacting equally but sluggish. He was moving all 4 limbs equally, and the other systems were within normal limits. Next. The treatment that the patient received was anti-edema measures, anti-epileptic drugs, and all the routine investigations were in normal limits. Now, the psychosocial aspects: he was a young male, unmarried, aspiring to develop his own business, and only child of his parents. Medications that this patient received were anti-edema, that is injection mannitol 100 ml 6th hourly, injection dexamethasone 8 milligrams intravenous 8th hourly, injection Eptoin 100 milligrams intravenous 8th hourly, injection levetiracetam 1 gram intravenous 12th hourly, and injection pantoprazole and injection paracetamol. The main concern was no further curative treatment was available, and how much is enough so that the patient's life is prolonged without compromising his quality of life and without prolonging his suffering. Now, to summarize, this is a 23-year-old male with glioblastoma multiforme, post-surgery, post-radiotherapy, now with radiation necrosis.
Which side was this, Dr. Vanita? And right-handedness?
Right frontal, sir. Right frontal.
Right frontal. Right. And he was right-handed.
Yes, sir.
Okay.
Now, the discussion points for the patient is coping with the prognosis, inevitable death in near future, his unfulfilled dreams, and the future of his parents. For the family, it is loss of their only son, not much therapeutic options left, futility of continuing care, and opting for invasive interventions versus conservative supportive care till end of life.
Okay.
Thank you. Yes, Dr. Roop, please.
Okay. So first is the prognosis. Now, one of the things that has changed in the past few years is that the gliomas, glioneuronal tumors, there is a lot of information available based on immunophenotyping. So if you have an immunophenotype, so IDT wild type versus mutant, I won't go into that. You can actually separate out various trajectories. They are glioma is no longer considered in that sense one single disease. So and we don't go by histology alone. We do need immunophenotyping. Not always available, but that's one thing that is important. Inevitable death in near future, dreams unfulfilled. So these become, you will have to tackle these and a palliative care unit will need to go through the counseling that is required. There is a certain amount of spiritual counseling also that comes up. And what we do is we actually literally just lend a shoulder. You cannot cope for them. So you actually have to give them a bit of tough love, that you listen to it. But you, if at all, I mean, you might help them find a way forward. If you have a social and IHBS should have a social worker and so on, then you involve the social worker in what facilities are possible and all that. The same applies to the family. So you are at this stage, you have started him on steroids, control the seizures. This is the stage at which the repeat imaging tells you whether the tumor has come back or whether this is just radiation necrosis and so on. I mean, if that is so, then you still have a fairly, possibly a prolonged trajectory still left. Are there more slides or?
No, that is it, sir.
That is it. So what happened to him finally? What was the story?
Actually, this patient, the imaging post decongestion was like it was suggestive of radiation necrosis, and but the tumor recurrence could not be ruled out, sir. Absolutely. So there was a diagnostic dilemma, and the patient's relatives were given the option. Like the patient had started developing more frequent seizures, and it was and the more anti-epileptic drugs were added. And even with that, like at one time he had developed status, and so we had to intubate him and put him on mechanical ventilation. And with just supportive care, he was also tracheostomized after 3 days. And then he had started developing signs of sepsis, and finally this patient succumbed, sir. But what could have been done was like when he was conscious, like even like on ventilator, in between he would still be responsive. So that was a state. So that, I mean, initially before we had intubated, we could have at least given them the option of just maybe like given him morphine just to control his tachypnea, which was central in origin definitely in this patient, and maybe allow him allow him to reach the end in a more
I don't really agree, because here you do not have a clear-cut prognosis. And I think the path that was taken initially was, I suppose, appropriate in the sense that steroids were given, anti-epileptics were given, that a tracheostomy was performed, all with the idea that perhaps there would be some survival. But then at some stage, sepsis goes out of hand. And yes, then you have to accept that you're dealing with a dismal immediate prognosis. But remember that this patient, I think the medium term, maybe the long-term prognosis was terrible, but the medium-term prognosis was still not totally clear. So I don't know. I mean, these situations are always difficult.
Yes, Dr. Shrikant.
There's actually one more question which is already there: CPR and advanced cancer patients in end of life care.
Yeah.
Okay, I'll quickly answer that. So I think all of us except think that CPR is like a ritual that has to be performed when somebody is dying. That's not so. And if somebody has advanced cancer, then it is a procedure that you can actually say that we will not perform. Procedures are not performed on patients' insistence. They are performed based on medical indications. CPR is a medical procedure. And if you feel it is not likely to help that given patient, you need not perform it. Ideally, you should discuss it so that this also gets documented through a do not attempt resuscitation order. But regardless of that, a CPR is a procedure.
There is one more question in the chat.
Yeah. Attorney magistrate signature. So, okay. So please understand one thing. The living will is valid if it is signed and witnessed, right? Valid. But to make it enforceable, so that if a judicial magistrate has signed out and if a doctor refuses to honor it, that doctor can then be charged for refusing to honor it. Yeah, but if it is validly made, if the family stands by it and a doctor follows it, then the doctor is protected, right? So two extremes. So if you want to enforce it, then the judicial magistrate first class is important. If everybody is aligned, family, medical team, then that document is enough to proceed.
Dr. Shrikant, you had a question?
Not a question. I just wanted to share that I would agree with sir in that at least in our rehab OPD, we have a good follow-up of patients with glioblastoma multiforme who come probably a year or so post their treatments, post their radiotherapy, who have fairly good functional status. At least they're not completely independent, but they would probably have, we would have people with residual ataxia or hemiparesis, but still are managing fairly well. And so we can't just let go in these young person with an unclear prognosis. May not be somebody who you would give up on in terms of intensive care. So I just wanted to share that and say that I agree with sir.
I agree. Yeah.
Sir, I have a patient. She's a 89-year-old lady, post CVA. She's completely bedridden, and she has only one daughter. She's settled in Bangalore, and her mother is taken care by and now it's almost for 9 months, I think. And I go every month there, and daughter calls me and asks me, how is my mother? How is my mother? She's on trials to fill. But whenever I see the patient is stable, I mean, patient, no, like, patient is not deteriorating, but now blood source also started. So only thing, what we do, like rides to feed, we change rides to
Every month.
Every month, sir. So whether to usually I also think what to do, like, what advice I should do, because every day she's paying around 1,000 rupees for that. Now for 9 months, it's too much. And she's the only one, and she's settled in Bangalore. So this question, I don't know how to answer. She may be expecting some negative this thing from me, but I don't think. Whenever I go, BP is stable, like almost one last time it was 140/90 or something like that. And she's only on simple medications.
So that's the reason why we say that for neurological illnesses, the end of life decisions are, it's a decisional issue. So a patient with multi-infarct dementia with Alzheimer's disease will eventually end up in a persistent vegetative state. And they can go on for up to 3 to 4 years.
Okay, sir.
Eventually the bed sores, sepsis will happen.
Okay, sir.
So I think what you should do is explain to the daughter that since she's not getting better, that at least you have to prepare for the end and make sure that the daughter is clear about not moving her to hospital. Make sure that CPR will not be performed.
Okay, sir.
And you can use the ICMR DNAR document and get it signed and kept ready there. So that as and when things end, they end peacefully. There
okay,
itself.
Sir. Then till then, rights to be continued, no, sir?
Now that is a tricky thing. So if the daughter, before putting in the rice tube, we prefer to counsel them and go on with what is called hand feeding. And as the oral feeding goes down, the patient also goes down, and life ends. But if a rice tube is placed, I think there is nothing against moving back to that once the rice tube comes out, not to put it back in again and to maintain with oral feeds and see what happens and just let the patient pass on.
Okay.
But that since the daughter is a sole, but then you have to be very clear that there is no other sibling involved and so on. All of that has to be clarified.
For that, ethically, we also feel some.
Yeah. So if you are the sole doctor on the spot, I think it's a little tricky. I would probably the line of least resistance is just to continue to do what you're doing. Don't escalate.
Okay, sir. Thank you, sir.
Thank you. There are no more questions in the chat. Thank you so much for the discussion and the presentation, Dr. Vanitha. So, Dr. Vanitha, thank you for the presentation so that we could discuss more on that. Thank you, Dr. Roop, for your time in your busy schedule.
You're welcome.
Thank you, Dr. Roop, for joining us. We do understand how busy your schedules are, and we are nearing the end of the day, and you are still active and answering each and every query coming your way. That is very much inspirational for each and every one of us. Thank you for joining us. We do look forward for more sessions from you. And with that positive note, this is Shritya along with Dr. Roop and Dr. Sridevi sign off from the Tips Eco Hub. See you in the next session with another interesting topic. Till then, everyone, stay safe, be happy. Bye-bye.
Bye.